Hi, this is Lisa Amaya Jackson, and I am pleased to introduce this podcast series. Our Category 2 sites have been discussing evidence-based treatment within an evidence-based practice approach, and while we have many EBTs we are proud of in our network, we wanted to take advantage of the fact that we can hear from a pioneering expert researcher in the field of traumatic stress on the evidence-based treatment she developed called cognitive processing therapy. Dr. Resick will share from not only what is the evidence for this treatment, but from the black box of how the use of research data informs the EBT and the shaping of its key elements and application so that it is translated into the best treatment for those clients that are seeking help for the target symptoms. Cognitive processing therapy is an adult treatment, and its application to the NCTSN is not just to learn from research and science, but also that it's a treatment that is being used in the NCTSN when we see a parent's need for treatment intervention as we work with them and their children.
This second segment is going to be talking about cognitive processing therapy, or CPT, and how it was developed and early research on it. I developed CPT in 1988 based on cognitive theory and therapies for depression and anxiety that were developed by Aaron Beck. I wanted a more systematic manual, one that would say what to do at each session, so it's a very prescriptive therapy manual. I did one open trial that was published in 1992 along with the first manual in 1993, and it focused on rape as the index event. I started working with rape victims as my first group of people, but as you'll see, people usually don't come to therapy with only one traumatic event. The original manual focused on rape victims and didn't emphasize the Socratic dialogue as much as we do now. It had extra handouts that we've removed. We've added other handouts. We have taken the handouts and simplified the language in them. The modules, the handouts that we use have been refined several times. But the bare bones of the structure of the 12-session therapy has been unchanged until we've published the newest manual in 2016. So the 12 sessions of the original protocol are as follows. Education about what is PTSD, why you might have PTSD, and how you got stuck in your recovery. And then you're given an impact statement to write as your first practice assignments. We give practice assignments at every session. The impact statement is a statement about why you think the traumatic event happened and how it has affected your beliefs about yourself and the world. And we focus on topics like safety, trust, power and control, esteem, and intimacy. The client learns about the connections between events, thoughts, and feelings with an ABC sheet that happens after session 2 when we work on now we work on a stuck point log. We didn't have that originally. But they're going to learn to start noticing when an event happens, that's the activating event that then goes to beliefs, and they have stuck points or beliefs about it, and that leads to emotions or feelings. And so that's where we got A, B, and C, activating event, beliefs, and consequences. The client's going to write a detailed account or narrative of the worst incident, and that's after session 3. Now, this is the old manual. We don't do that anymore, and I'll get into why we've changed that. But the original protocol was for them to write a detailed account or a narrative of their worst incident, and that would be called their index event, including sensory details, thoughts, and feelings. Between sessions 3 and 5. In other words, they're going to do that twice, read it to themselves daily. And the therapist is going to start doing questioning and looking for stuck points that they're going to challenge. Sessions 5 to 7, we're actually starting to move into teaching the client to do cognitive therapy for themselves. So we're going to teach them how to challenge a single thought, a single stuck point, using challenging questions, and those would be the kind of questions that the therapist would ask. So the therapist is modeling it in the first few sessions. Then they're going to learn about patterns of problematic thinking. which are those tendencies to jump to conclusions or overgeneralize from a single event, mind reading, emotional reasoning. We'll get into some of those. And then the challenging beliefs worksheet is the final worksheet that we move to and use through the rest of the therapy. And that includes all of the previous worksheets plus a final column for an alternative thought that's more balanced, more fact-based, and then we ask them to rate their emotions if they practice believing that new thought. So sessions 8 through 12, we focus on what we call over-accommodation or over-generalization of thoughts. So they're stuck points. In the first part of therapy, we're focusing on the event itself. On the second half of therapy, we're focusing on the aftermath, how that event has changed their beliefs about different kinds of topics. And then they can continue on with their own stuck points that are unique to them, but we are gonna hit certain topics: safety, trust, power and control, esteem, and intimacy. And any of those can be either self-referent or other-referent, meaning self-safety, I can't take care of myself, or other safety, people are dangerous, or the world is dangerous. Trust could be self-trust, I don't trust my own judgment anymore, or I don't trust other people, and so forth. Toward the end of the therapy, we have some behavioral assignments for doing nice things for yourself and practicing giving and receiving compliments. We start moving toward facing the future. When we get to self-intimacy, that maybe is beyond self-esteem, and that is kind of what do you want to do with your life? Who do you want to be? What are your values? How are you going to spend your time if you don't have PTSD? Can you graduate from your PTSD? Or can you retire from your PTSD? And then the last assignment before session 12 is that we ask them to rewrite their impact statement. Now what do you believe about your traumatic event? So after I conducted, it took me 84 pilot cases before I was finally awarded a grant from NIMH in 1994 to compare CPT to prolonged exposure, which had been recently introduced at that time, and a waiting list, which is a delayed treatment followed by randomization to either CPT or PE, and PE is prolonged exposure. The grant followed up with the participants for 9 months, but if they dropped out, they weren't invited back just due to the statistics that we had available at the time. Now we tend to ask people to come back even if they quit therapy so that we can continue to look at them. But we did have enough money in saved grant money that we were able to ask them back 5 to 10 years later for a follow-up, and we asked everybody to come back, whether they got therapy at all or whether they completed therapy or not. So that was what we call an intention to treat. So here's the first study that was published based on that first grant, and we compared CPT, prolonged exposure, and a waiting list control, which is the delayed treatment for PTSD. We assessed 267 women. For the most part, if they did not come into therapy, it was because they didn't meet the criteria for PTSD. 181 were randomized into the trial. 10 were terminated from the trial, meaning that they met the exclusion criteria. So we had 171 in our intent to treat sample, and that means we intended to treat them. So that's what we do analysis on, particularly since 2005, 2006, most studies are going to present intention to treat. Because if you just look at the treatment completers, there might be a bias into who drops out of which treatment. So we had people who went directly into CPT or prolonged exposure, PE, or they were in the delayed condition group and had been randomized to CPT or PE. There were some people that were in the delayed condition group who didn't go on and receive therapy. 86% of the participants had traumas in addition to the index rape. 41% had child sexual abuse. The number of adult crimes, this isn't other kinds of traumas like car accidents and so forth, but the number of adult crimes averaged 6. So that more than half of them had at least one other rape, and more than half had physical assaults, many of them were domestic violence. I was surprised that 26% had homicide or alcohol-related vehicular deaths to a close friend or family member. So we tracked the other kinds of events they also had. I'm showing you this so that you understand we were not doing some ivory tower study. We were doing a community sample, and this is typical of most of the research that's been done, is that we take in just about everybody and have very few exclusion criteria. Imminent suicidality or homicidality, if they're at the time, if they were actively addicted to drugs or alcohol, they could come in later, maybe some years later in the study or 6 months later if they've gotten off of the substances. But if they were addicted, they were ruled out. But we did not rule out anybody with personality disorders, any other comorbid psychopathology, any other psychological disorders were included in the study. This is the intent to treat sample. I've told you what intent to treat means. That included people who didn't even receive any treatment at all, and there were, I think, 13 who didn't get any therapy at all, and they're included in here. So we did what was called last observation carried forward, and this is the clinician administered scale, which is an interview that's done by an independent interviewer who did not know which treatment they were in. So you can see they all look pretty much the same at pre-treatment. And at post-treatment, you can see there's quite a bit of a drop when they got treated directly. Here's our delayed treatment group. They don't improve over the 6 weeks. We were doing 2 sessions a week for 6 weeks. And then as soon as they got therapy, they looked just like the group that got treated immediately. And looking over the 9 months, you can see there's no difference. CPT and PE worked identically. Now, looking down here, this is what we call an effect size. A small effect size would be about a 0.3, a medium effect size about 0.5, and when you get about a 0.8 effect size, that's a large effect. And this is the way we can compare across different kinds of studies with different kinds of measures to see how big an effect do we have. And as you can see, CPT versus the delayed treatment group, that's right here, the blue line versus the green line, was a large effect size. It was a medium to large effect size with prolonged exposure. And then when we compared CPT directly to PE, very small effect size difference, nothing worth writing home about. They both treated PTSD equally well. Now here are our people who actually completed treatment, and you can see at the bottom the effect sizes are much larger. Those are huge. But there's still only a small effect size difference with CPT versus PE. But you can see there was about a 75% drop in their symptoms, and 80% lost their PTSD diagnosis if they got one of these 2 treatments. And that's over a 6-week period with just 12 sessions. And the same thing happened when we get the delayed treatment group treated as well. Only about 26% of people dropped out of treatment, which is lower than you typically find in a clinical practice. So here's the diagnostics, and you can see that 80% lost their PTSD diagnosis. And then if you look at the delayed treatment group, of course, there was almost no loss of diagnosis over that 6-week period. Now here's the long-term effectiveness of CPT, and as far as I know, it's the longest follow-up that's been conducted on a PTSD trial. We contacted people, they were anywhere from 5 to 10 years post treatment. We had 171 who were in that intention to treat sample, and we attempted to reach all of them. We could not locate positively 27 of them. 3 were deceased, 2 were not appropriate. They were now meeting criteria that would have been exclusionary. One person got off their bipolar medicine. We could tell on the phone that they were manic. There was another person who was drunk, so they were excluded because of the validity of their measures were not assured. Only 11% refused to participate. So of the original 171, of those we were able to contact 126, which was 87.7% 87% of the number we contacted, and that was 70% of the original sample. I was very excited with that kind of response rate. We got at least the caps from them, and in 119 of them, we got all of the measures that we got at pretreatment. This is showing the PSS instead of the caps because I wanted you to see how they look over treatment, where it says weeks 1, 2, 3, 4, 5, 6. This is sessions 2, 4, 6, 8, 10, and 12. Here they are at post-treatment, 3 months, 9 months, and 5 plus 5 to 10 years later. On average, it was 6 years later that we actually reassessed them. The exciting news is once they're treated, we didn't see relapse, and we did look to see if they had had other treatments. 59% did have other treatment, but they tended not to get treated for their PTSD. They were getting treatment for something else, like marital problems or obesity or problems with their children. So we took that as a good sign that they had a good experience with therapy and decided to get more. We also looked to see whether they had other traumas, and many of them did, but they didn't relapse on their PTSD or develop new PTSD. We also had published a lot of papers because we did a lot of measurement on other kinds of symptoms. We looked at depression across many studies, and depression tends to decrease right along with the PTSD. Where you're going to see the little asterisks there is that CPT did better than PE in several respects. Because it's a cognitive therapy, it did better with guilt, and that continued all the way through the long-term follow-up. That's the 2012 paper. Reported health symptoms were a bit better for CPT than PE, and those were some initial findings that we don't have the long-term follow-up on that. Anger was a little more complicated. There were no differences in outcomes, but the people who had very high levels of anger were more likely to drop out of PE than CPT. Age was an interesting finding. Younger clients tended to do better with CPT, where the older clients did better with PE. We think maybe because of cognitive flexibility, the younger clients were able to change their thinking quicker and more efficiently. Older clients maybe needed those repetitions that you would get with prolonged exposure. We've now been modifying the therapy for older clients, adding more repetitions of reading the worksheets and so forth. Hopelessness was another measure that was looked at. One study looked at hopefulness and found that to be a predictor of treatment outcome. When we looked at hopelessness, we found that was a significant difference over the long-term follow-up. Suicidal ideation, both groups improved, but the group that got CPT improved more on their suicidal ideation. There was no difference on social and work functioning. They both improved. So these were improvements across the board. It's just in some cases CPT did a bit better than PE. There's now a very large study being conducted in the VA that's almost done, over 900 patients being treated comparing CPT and PE, and they're using this version of CPT, the version with the accounts. So in about a year or so, we'll see the findings of that and see if they're similar to the findings that we found with this original study. This is the only study that has compared CPT with PE. There were a number of papers that we did where we collapsed across CPT to PE to get a larger sample, and in fact, in one case, we've collapsed across a couple of studies, and we haven't even gotten to one of those studies yet. We found that borderline personality characteristics at pretreatment didn't affect PTSD outcome. In fact, they intended to start out higher on their PTSD, and they improved at a steeper slope and ended up in the same place as people who didn't have borderline personality characteristics. When we looked at the long-term follow-up, we gave them the scale again. We didn't give it to them during those shorter follow-ups, but we did give them to them at the long-term follow-up and found that there were changes in PTSD symptoms were related to personality changes, particularly paranoid personality, schizotypal, antisocial, borderline, avoidant, and dependent personality. So we saw a lot of changes in personality itself once the PTSD had been improved. More frequent sessions results in greater PTSD reduction. That even though we were trying to see them twice a week, that didn't mean that always happened. And so the first author of this paper, Cassidy Guttner, looked at how many days were between sessions and found out it wasn't the consistency so much, it was the frequency of sessions. So the faster you can treat somebody, the better the outcomes. We now have a study that's going to be starting soon that's going to be looking at CPT done in 1 week. We looked at the dropouts, and this was across 2 different studies because we had to have enough dropouts to actually look at them, and found that 37% of the dropouts actually had a good end state at the time they dropped out. So that dispelled one of our myths that people drop out of therapy because they're running away or they're not doing well. In fact, sometimes people stay in therapy because they're not doing well. And sometimes people leave and don't really care that we're doing research. And so they're happy with where they are and they just stop. A more recent paper is that doing the practice assignments results in greater improvement in PTSD symptoms. So it is very important that they do their practice assignments and that you need to keep reminding them to do their practice assignments every day. So take-home points. CPT was subjected to pilot data before applying for a randomized controlled trial. CPT was not just compared to a waitlist control, but also to the best other available treatment. We were able to conduct a long-term follow-up and found no relapse. Once they are treated, they're better, even though they may have experienced other traumas. They've learned to handle them differently and to think differently, and that's part of what CPT is doing, is to teach them to be their own therapist and to learn a different style of thinking than they've been doing before. Because PTSD is so comorbid with other symptoms and disorders, we examine many other things. The list I just showed you is not an exhaustive list. Some compared CPT and PE, and some examined other symptoms or other aspects of treatment.